Hello, everybody. Welcome to Grand Rounds. A few people are still logging in, but we'll take this minute to welcome everybody, and a particular welcome to our special guest, Dr. Surafel Tsega, who is a board-certified hospitalist, a clinical informaticist at the Mount Sinai Hospital, and also the director of informatics for the Department of Medicine, where he is particularly focused on high-value care, quality improvement, and equity. Dr. Tsega, thanks for joining us today. Take it away.
Thank you very much. And thank you everyone for having me. I'm really happy to be here. I hope that we can have a little bit of participation, even though we're still in the world of Zoom. But feel free to ask questions or throw them into the chat whenever you have one. So first, I'd like to say I have no actual or potential conflicts of interest. I just want to get that out of the way. And I want to start with a clinical vignette. I'll read it out loud, and I'll get back to this towards the end of the talk. But Mr. R is a 28-year-old sickle cell patient with chronic left hip osteomyelitis who comes to the ED stating he has 10 out of 10 pain, quote, all up in my arms and legs. He is narcotic dependent and in our ED frequently. At home, he reportedly takes 100 milligrams OxyContin BID, oxycodone 5 milligrams for breakthrough pain. Over the past few days, he says that he has taken 2 tabs every 4 to 6 hours. About 3 months ago, patient states that the housing authority moved him to a new neighborhood and he now has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. Yesterday afternoon, he was hanging out with friends outside McDonald's where he wheeled himself around more than usual and got dehydrated due to the heat. He believes that this, along with some stressful situations, has precipitated his current crisis. Pain is aching in quality, severe, 10 out of 10, and has not been helped by any of the narcotic medications he says he has already taken. On physical exam, he appears to be in distress. He has no fever and his pulse ox is 96% on room air. The rest of the physical exam is normal, although he reports tenderness to palpation on the left hip. So this is an example of an H&P from a study that was presented to ED providers. I just want you all to kind of take a moment and think about, one, the thoughts that are going through your head as you're reading this, both clinical and non-clinical. Two, what jumps out at you about this description and this H&P, and 3, what were some of the things that you noticed that you gravitated towards in terms of thinking about what the next step would be in the care of this patient. So first, just a sort of brief outline. We're going to talk a little bit about the OpenNotes movement, because that's one of the reasons why I'm here to really, make you guys all aware of that. Then we're going to talk about the early impact of notes, of the OpenNotes, and then focus on the importance of language now that our patients are able to more easily see our notes. So first, just something to keep in mind as you're typing your notes away. So the OpenNotes project was launched in 2010, and it's really more of I would really describe it as a movement more than anything else, because it really was a grassroots movement that started in a few medical centers across the country at Beth Israel Deaconess, Geisinger, and Harborview in Seattle. And this involved about 105 primary care docs and 20,000 patients that were eligible to participate. And this study went over a couple of years, and eventually they published their manuscript within the Annals of Internal Medicine in 2012, looking at their experiences. And what they saw, essentially, just to make sure we're all on the same page, I should stop and say OpenNotes meant that a patient was able to log into a patient portal and see their physician's note from their outpatient encounter once the physician had finished signing the encounter. So once the note is complete, the patient was able to see their notes, and the access of notes was tracked through their online portal. So what did they see? They saw a lot of good things when you're talking about making notes accessible from a patient perspective. So an overwhelming majority of the patients that were surveyed felt that having access to their notes made them feel more comfortable in control and more in control of their own care. Again, another pretty impressive majority felt that having access to their notes also made medication adherence a little bit easier. The less than half, so anywhere from 20 to 42%, and this range varies by each location more than anything by each location, reported that they shared their notes with family members or other individuals or their surrogate as well. And then lastly, interesting to note, only 1 to 8% of patients reported that the notes caused some confusion, some worry, or some offense. So a small group overall, certainly, but something that I think we keep in the forefront of our heads when we think about giving patients access to notes. So for those of you who have worked in the VA or rotate through the VA, you'll be familiar with this blue dot, which is essentially the patient portal for veterans in the VA system. And early on, after that initial study came out in Annals of Internal Medicine, you saw a slow growth of this open notes movement to include the VA. And then ultimately, by about 2015, there were over 50 million patients nationwide who had direct access to their doctor's notes. So really from 2010, where less than 20,000 really known patients having access to it, to now jumping to 50 million patients over the course of 5 years, is an incredible leap forward in terms of giving patients access to their care, and something that I think the individuals who really started this movement should be commended on. And so this movement really going from 2010 to, getting a large number of individuals on by 2015 really culminated with the 21st Century Cures Act that was signed by President Barack Obama back in 2016. And there's definitely a lot to the 21st Century Cures Act, but a couple of things to sort of highlight. One, it did modify the FDA drug approval process, for better or worse, depending on how you look at things. It did also offer funding for treatment for rare genetic diseases. It created an exemption for FDA regulation of medical software. And for the purpose of this talk, what's most important is that it increased and mandated access to the medical records for all patients. So after several years of trying to figure out how this would ultimately be implemented, the federal government finally released a rule in April of last year that required all healthcare providers to give patients access without charge to all the health information in their electronic medical records without delay. So what does this mean for you in practice? Across the Mount Sinai Health System, you should know that any normal lab result is released to the patient automatically or within 24 to 28 hours. If there's an abnormal lab result, that's usually held and then released after 28 hours. For microbiology, pathology, and certain other sensitive tests that release to MyChart and the access to the patient is not granted for about a week at most. And to be honest, Mount Sinai is probably on the more conservative end in terms of how it is releasing notes to providers. There are other institutions that have shorter durations in terms of providing normal results, abnormal results, or even radiology and pathology results. In the outpatient setting, they had already started making notes available to their patients, but it wasn't until a little bit later on that right now, on the inpatient side, doctor's notes are available to patients once the discharge summary is signed or 30 days after discharge, whichever comes first. And it's only doctor's notes at the moment. So no nurses' notes, respiratory therapy, etc. There are certain carve-outs for pediatrics and for psychiatry, but those are probably going to change as the government issues additional advisories on that in the coming years. So at this point, really we have entered a world where the patients have direct access to their chart without having to go through medical records and can really access it on my chart or whatever patient portal is available to them at their institution. So what hath we wrought? So first, I want to take a look at some of the clinician attitudes. And I think this is really where a lot of the hesitation comes from, is the fear of giving patients access to notes that wasn't necessarily available to them beforehand, and we're giving them access to notes that wasn't necessarily written with them in mind. Concern about using a lot of medical language, concern about casting judgment or giving a prognosis without having told the patient. There's a lot of hesitation about this. So taking a look at this first study, looking at clinician attitudes, you see a pre and post implementation pretty impressive change in terms of feelings. The pre-implementation of the study group was very skeptical about making the notes available being beneficial, but post-implementation, overwhelming majority agreed. The concern about visits taking longer in the outpatient setting also decreased significantly. The same is true about requiring more time for questions as well. That decreased significantly. And providers were also worried about having to spend more time on their notes to make the notes more understandable or readable or clearer for patients. But it turns out that didn't actually bear out. So a lot of the pre-implementation fears that the providers had didn't really necessarily bear out in terms of their experience with OpenNotes. And I would argue probably for all of you on the inpatient side that you probably have noticed a negligible change in having your notes be available, and you aren't getting dozens of calls from families after discharge asking about X, Y, or Z thing that was written in the note. There are a lot of other studies that have looked at the effects of OpenNotes, and I just wanted to highlight some of those changes here. So interestingly, the concern about patients contacting their doctors as a result of a note, that was definitely a big concern for providers, but only 7% of patients in one study reported having to contact their provider after reading a note. 14% of patients in another study reported contacting their physicians outside of the monthly visits, but really going to the last one, no change in the amount of email communication. So, overall, anywhere from 7 to 14%, depending on the study that you're looking at, is not a significant burden on the providers. Granted, these are all ambulatory providers, but I think that to that point about no change in the amount of email communication, that is something that's definitely important, particularly when you think about your in-basket and how full it can get. Um, Another study looked at the duration of visits pre and post implementation of OpenNotes and really saw no duration of visits. So again, the physician concerns about longer visits wasn't borne out in the reality. Some physicians did in a different study did spend additional time with documentation, but again, not the overwhelming majority. And though it's not a really resounding yes, in one study, about 61% of providers would recommend this change to their colleagues. All right. And so the interesting thing, there are definitely studies that I haven't presented here that showed that focused on attendings and more senior providers, but there are studies that also looked at resident concerns as well, and in the same vein, residents had the same concerns that their attending colleagues had, and those concerns weren't borne out in their real experiences. So really, these concerns kind of cross the spectrum of experience and are almost on some level ingrained in the culture of medicine, but hasn't necessarily been borne out in the experiences that we've had so far. One other interesting thing to think about about OpenNotes is that it has expanded or made access to care or improved the type of care that is provided to patients who come from underrepresented minority groups, or for patients who have low health literacy. And I think many people would find that this would be counterintuitive in terms of having notes that have a lot of medical language, a lot of medical jargon involved, and how that can necessarily lead towards improvement in care. But this study in particular showed that a lot of patients found significant benefits. So looking at patients who had less than a high school education, or Black patients or Hispanic patients in particular, overwhelming majorities reported that the notes were extremely important to feeling informed about their care. So having access to the information felt like they were getting all the information, really getting all the information that they needed to know how to take care of themselves and what was going on with them. So very empowering to have access to data that was, previously siloed or hidden behind a wall of medical records, request forms, costs to obtain those records, faxing, etc. Again, greater than 60% across all three groups felt that having access to the notes was really important about remembering their plan of care. So leaving a visit and trying to remember, what did my doctor say about the change to my lisinopril medication? So again, giving them access to data, giving them an opportunity to review what had been discussed with their provider, and on some level actually saving the providers an extra call or two. And then lastly, there was, among the patients with the poorest self-reported health, 66% found that the notes were extremely important to be informed and to understand the provider. So really, the theme across all of these questions and all of these experiences is really empowering the patient, giving them access to the data, and helping them be able to keep up with taking care of themselves, and empowering them to be able to do that more. So definitely a lot of benefit from the patient perspective as well. So shifting gears a little bit, I want to talk about the importance of language in the era of OpenNotes. So this came out in February of last year. And I think before I get to that, I do want to acknowledge that some of the previous studies have shown that the percentage of patients who have had confusion or who have been offended by the language that they've seen in the notes from their providers or physicians is small overall. But I do think, and one of the important themes of this talk, and one of the important takeaways when you're thinking about destigmatizing your notes is really thinking about how our description of patients, how we talk about patients, how we write about them, how that points towards certain biases, and certain prejudices that may not be born out directly with one individual, but maybe something that may be a pattern that we really should think about and stop and examine ourselves and look at why we perceive patients to be a certain way or not. So this was published in last year in the Journal of General Internal Medicine, and this study found that 10% of patients who had access to their notes and actually reviewed their notes felt that they were being judged or were offended by what was written in their documentation, in their notes, in their chart. And I just wanted to highlight a couple of the experiences. So a note in my file was put together using boilerplate cut and paste and includes several errors, including some of my conditions, family history, and my age and sex. It suggested a level of carelessness in record keeping. I find this one to be relatively powerful because, we all fall victim to copy and paste. We all fall victim to the demands of billing and what will get us a level 3 versus a level 2, et cetera. And so it's interesting that from the patient perspective, this patient in particular felt some frustration that the notes didn't necessarily feel like it was personalized to them, and that the errors that they found really showed some degree of carelessness. So the doctor reports having made a number of statements and recommendations that he did not make. This one seems very obvious, but I know a lot of times, a lot of documentation, especially when you're talking about procedures or for individuals for providers that are providing chemotherapy, or for our surgery colleagues, et cetera, there's extensive documentation about the risks and benefits that were discussed, et cetera. Sometimes, people have doc phrases or templates that include that information, but the patients do remember if you actually discuss that or not. So again, another, while not necessarily about bias or prejudice per se, having access to their data does give the patient an opportunity to say, wait, you didn't talk to me about this. Why aren't you talking to me about this? Or why are you saying you did, and when you in fact didn't? So it does require us to be on our toes and to be very diligent about what we're actually documenting. The diagnosis on the notes was that I was suffering from depression, but the doctor did not even mention that to me on the visit. That is what makes me keep reading the notes, to know what the doctor really thinks about me, but did not say to me. That was very disappointing. Again, I think this is another important point when you think about giving patients access to notes. In this instance, the concern was about a potential diagnosis of depression, and there is definitely some concern, from the patient about not being told that they probably have depression and they should, seek treatment for it. But you can also think about something about being transparent to patients who are critically ill, have been intubated, and who are on pressors. And if you're writing in the note that they're critically ill and that they may not survive the hospitalization, that's important information that we really should be communicating with the patient's families, and not something that they should find out in the note after, the discharge or after the patient is deceased that, oh, wow, my doctor thought that they were very sick and I didn't really appreciate that. I think the same is true for oncology and prognosis as well, as trying to be as transparent as possible. And I think the open notes movement will probably make people a little bit more cognizant of that and a little bit more cautious about how, more cautious about what they put in the notes is certainly an issue. Comments around my being gay, which I think sort of speaks for itself. And then lastly, provider called me elderly, insolent pup. I thought that was just a cute little phrase. So obviously, be cautious about those types of things. In the chat, there was a question, or there was a comment about things being in the chart, that once they're in the chart, they can't come out. There are instances where patients can request that an error be corrected. And there is a process at Mount Sinai for you to go about correcting those errors. They usually send a request through the patient services office, and you can make those changes if you feel that it's appropriate. Because everything is electronic, each draft of a note is maintained. So if you were to audit a note, you would be able to see all 7 versions of a particular note and see that a change was made. So while yes, there is some degree of being able to correct the documentation, there is definitely a mechanism for that. But the commenter did also bring up that there are issues with the problem list and medications. And unfortunately, that is one thing that once it's set in stone, once it's put in the chart, it's not able to come out of it. So again, that is an area where you sort of have to be cautious about what you set as a problem. There have definitely been some instances where I've seen offensive things free texted into a patient's problem list problem, and that being available and the patient actually getting the records and seeing that. So the documentation around problems lists is definitely something that is its own disaster, for lack of a better word. But another place definitely where you should be cautious about about what you're typing, and making sure that, again, you're being professional in all settings, and also making sure that the problem list is as up to date and accurate as possible. But yes, that is a good point about problem lists. So that I just want to go back to that clinical vignette that we talked about, and we'll go over it as a group in a sec, but that vignette was presented to a group of ED providers, and they were asked to to give their attitudes towards the patient depicted in the vignette. There was a second vignette that was written that had a more neutral tone, and providers were asked to provide their attitudes and a treatment plan recommendation based off of that. And so what they saw was that for the providers who read a clinical vignette with more neutral language, they were more likely to have more positive attitudes towards the patient than the providers who had the stigmatizing language in the clinical vignette. So that description that I had at the beginning was the example of stigmatizing language. Again, that the use of the stigmatizing language actually translated into a difference in how the providers said they would manage that person's pain. So if neutral language was used, they were more likely to be more aggressive with their pain management. But for the providers who were provided with stigmatizing language, they were less aggressive with their pain management. And this is really getting to the point that I had been mentioning before, that for patients, that the biases and the words that we write in in our notes may not necessarily offend a patient, may not even be seen by a patient, but they do hint at some of our own prejudices that can affect the type of care that we provide to patients. And there has been several studies that have really looked at patients with sickle cell disease in particular. Obviously, this example is from there. A majority of patients with sickle cell disease are Black, and so the racial implications of a disease where you're prescribing opioids and managing pain, thinking about the years of systemic racism in terms of downplaying pain for Black patients or African patients in particular. It definitely all plays into that. And you can see that in the documentation when people talk about patients with sickle cell disease. Interestingly, something as simple as the term sickler was associated with more negative attitudes towards patients with sickle cell disease. And I don't know if you recognize some of those names, but Jeffrey Glassberg is a physician here at Mount Sinai Hospital at the Uptown campus. And he's an ED physician, but he sees, essentially all of the sickle cell patients at our location here. Separate from the idea of using sickler, alcoholic, cirrhotic, or even something like diabetic, the way in which we describe patients who have substance use disorders can potentially be indicative of biases that we may have that may ultimately affect the type of care that we provide them. And this actually just came out within the last 3 weeks, actually. This is in Health Affairs in 2022, and a group of individuals at a academic institution in Chicago. I think it was Northwestern. I can't remember offhand. Interestingly, they used a machine learning model to identify positive and negative descriptors in about 18 or 20,000 patients who had H&P notes over a 2-year period that spanned the year prior to COVID and then the year of COVID. And now this is one study, but definitely something that was interesting and a little bit thought-provoking. Again, so what you're looking at here is their main table looking at the total number of patients where they had either a negative patient descriptor in their H&P in at least one episode or one use of a negative descriptor in the EHR or none. And I highlighted here the patient characteristics for Black patients in particular. So you can see that of the 11,000 patients who were identified as Black, that an overwhelming majority did not have a negative patient descriptor. So so definitely something that's reassuring. But if you look over to the far right, what you see is that if a negative patient descriptor was found in an EHR, it was most likely going to be found in a Black patient's chart. So the overwhelming majority of patients who were Black or who had negative descriptors were Black. And the odds ratio that they calculated was 2.52 that you would find a negative descriptor. And so this, really, gives me gives me pause and should hopefully give you pause as well to think about when you are writing those negative descriptors. The patient is aggressive, the patient is refusing, the patient is non-compliant. Who is the person that you're talking about? What are the socioeconomic factors that play into the situation that they're in? What are the societal failures that play into the situation that they're in? And sort of thinking about what, how that affects the patient, both how that affects the patient and how you care for them, how you present that patient to your colleagues and affects how they care for them. I think that's a really important point to keep in mind, and just something to be mindful of. So I wanted to come back to this example here. And I know that it may be a little bit difficult, but if anyone wants to come off of the chat just to highlight any of the statements where they feel that there might be stigmatizing language in the clinical vignette that I presented at the beginning. Feel free to unmute yourself or raise your hand or.
Justin.
Yeah, I had a few thoughts about this. I thought the things that were quoted or in quotations are maybe not things I would want quoted. So all up in my arms and legs, it's not specific, and it doesn't seem to add a lot to the vignette. I think stating that a person has 10 out of 10 pain, or stating that they have 10 out of 10 pain is different than saying they have 10 out of 10 pain. And I think we all recognize that this is the subjective portion. So we know that the patient stated this. So it seems redundant to say that he stated it, or to say that the patient stated that the housing authority moved him. So those are a few things I picked up on.
Yeah, those are all great points. And the idea of what we put in quotations in the patient chart, I think is very interesting and up for a lot of introspection when we think about it. The all up in my arms and legs, this definitely the African American vernacular English is really what that's sort of giving off. At least that's how I perceived it. And it does remind me of situations where I've seen providers in notes write for a Spanish-speaking patients that they have quote total body pain or total body dolor. I've seen that in charts before. So again, ways that we are presenting our patients in words that are stigmatizing, when in something more neutral, you could say the patient has generalized pain in their extremities, or the patient has pain in their upper extremities and their joints and their lower extremities, which is typical of their pain crises.
Great. And then Dr. Litzk and Dr. Chen are pointing out narcotic dependent is a problematic phrase, and also frequent visit to our ED is not objective language.
Right. So those are also great points. I think, frequent visits to the ED or is known to our ED, that's definitely language that can tip the provider off one way or the other, when instead you may say that the patient has severe sickle cell disease with recurrent hospitalizations. Again, that's a little bit more objective than coming into our ED frequently or being a frequent flyer. I've definitely seen that in patients' charts as well. I do want to. So these are some of the things that have been highlighted, at least from this part, and then we'll go to the next one. The one other thing is notice how the provider casts doubt on how the patient is taking their medications at home. So at home, he reportedly takes this. He says that he has taken, etc. Again, they're casting doubt on whether the patient is actually, ascribing to the pain regimen that they had been prescribed to. So another point where they're casting doubt on the patient's experience. And then moving along, oops, looks like I overdid it, but you can definitely see, I think there may be a couple of other instances that I'm hoping that people can highlight. I'm just being mindful of the time, that also stands out to them in terms of stigmatizing language or unprofessional language or really unnecessary language.
I don't think this quotation mark for stressful situations is necessary.
Right, yes. It again casts doubt on the patient's experience that whatever they think they have in terms of a stressful situation may not necessarily be stressful. And some of these, I know that some individuals may sort of hear this and think that this is being a little bit nitpicky in terms of how something is being written. But I think it's important to think about, why the provider has decided to make those a quotation mark rather than other aspects of the patient's history. And that is really the important thing, is that the selective use of quotation marks is really evidence of bias or prejudice that's casting doubt on the patient's experience. And I think something that you have to sort of be mindful of. There's a lot in the chat as well.
Thank you, Dr. Barger. Putting on comments, judging his statement about what he was doing during the day leading to hospital visit.
To get into it, right, the term hanging out with friends, is that a bad thing? But the way that it's stated, there's a lot in here that's socially loaded. As Dr. Tsega said, the targeted use of quotations, it's selective. It leaves the power in the hands of the author, not of the patient, and a whole bunch of other things in this note.
Great, thanks so much. Yeah, exactly. And the one other thing that I wanted to highlight actually is how we describe patients in the physical exam can really be telling when we talk about bias. And I think, there is a tendency to use a lot of term to be as descriptive as possible in a physical exam. But here, it's telling that, the patient appears to be in stress rather than the patient is in distress. Just thinking about that. And you can also think about the description of the physical exam, that he reports tenderness to palpation of the hip. So the idea of, if you say that someone is tender to palpation on the left hip, that should be sufficient. To say that he reports it, again, casts some doubt. And so, some of this may definitely be for some individuals uncomfortable or provocative, but part of that is to, feel a little bit more uncomfortable and think about why exactly we're using particular language in the way that we are, and how does it in some small way precipitate some of the larger political or socioeconomic or racial issues that we know we're dealing with on a day-to-day basis. So really, I just kind of taking a step back, definitely after hearing, really for me, the groundbreaking thing that had changed the way that I wrote about patients, and over time continues to change the way that I wrote about patients, is that a mentor in residency who I adored and respected greatly talked about how terrible she felt when she heard a resident say that her dad, who's very sick, was quote a disaster. And that idea that really like stuck with me, that, you know, would you describe the patient to their face the same way that you would behind their back when you're talking about them in the resident room or when you're talking about them in their note? So again, it's moving away from judgmental or stigmatizing language like avoiding sickler, cirrhotic, or alcoholic. That's what's led to alcohol use disorder, opioid use disorder, etc. Again, I think one area where we see this happen frequently is patient decline, so the patient refuses instead of patient declines or chooses not to. My patient yesterday, quote, refused vitals at 4 a.m. He was stable. He was going to be ready for discharge in the morning. He had a reasonable reason to decline labs because he didn't want to be woken up. But when you see that patients are refusing this or that, it definitely, creates a different sense of what it has negative connotations, I think, and it's something that you should be careful about. Avoid certain descriptions in the physical exam. There are things that we think are cute, but other individuals may not necessarily want their loved ones to be described as pleasantly demented, something to be mindful of. Avoid casting doubt on the patient's symptoms, as we talked about. And then I think one that isn't talked about much, but reconsider documenting personality type descriptions. Does every patient that has a personality disorder, does that really need to be in their one-liner if they're here with a CHF exacerbation and their personality disorder is not of relevance? It's something to be mindful of when you're writing that one-liner. So I'm just going to leave you all with a quote from PhD. When we think about our patients in a kind of language that we deem inappropriate or potentially offensive to the uninitiated, who is to say that our own attitudes towards our patients are not affected by that language? Wouldn't we be closer to our patients' experience if we got into the habit of thinking about them in language they would find meaningful and useful? I think this is a powerful quote and really sort of summarizes how I am trying to continue to change the way how I write about patients or how I talk about patients with residents and colleagues. So very quickly, if anyone has any hesitations about OpenNotes, if you just search OpenNotes, you can find their webpage. It has a compilation of every single study that has looked at the effect of OpenNotes on providers, patient experience, clinical outcomes. There aren't that many on the latter, but definitely a great resource if you want to look into this a little bit more, especially if you're skeptical or hesitant. And I think that's it. I'm just going to leave some time to answer some questions or any comments or anything.
Thank you so much, Dr. Tsega. Any comments or questions from the audience?
So there was one question that I see in the chat is there a list of proper words or phrases recommended for non-compliant or problematic? I haven't actually been able to find one. I think what I had seen previously is the idea of moving from non-compliant to non-adherent as having less negative connotations. But interestingly, in that health affairs study that I cited, the health affairs studies that I cited earlier, they included non-adherent as being a negative connotation. So I think to the point of exploring the barrier, which is what Dr. Berger just mentioned in the chat, and thinking about the reason may be more important than necessarily saying that the patient is non-adherent or non-compliant. Is the patient non-adherent because they can't afford medications? Is it because they are homeless, etc.? I think an opportunity to explore that further. And maybe you could even argue that rather than saying the patient is non-adherent to medications in their one-liner, in their in the H&P, you can talk about, the patient has difficulty managing medications because they cannot afford it, or because of pill burden, etc. So removing it from that one-liner and turning it into something that is a phrase or a sentence, or really exploring that reason in more detail, is definitely one way that you can avoid using that problematic language. But if you do search online, and I can definitely share it, there are some institutions that have created their own best practices for words to avoid that I can definitely share with you all afterwards.
Thank you very much, Dr. Tsega. And also thank you, Dr. Grabshade, Dr. Raghavan, Dr. Border. Any last minute comment or questions?
One other thing that I wanted to add is that, this talk has really focused on documentation and note writing. But like I said, in terms of the, in describing that anecdote about my mentor from residency, it's not just how we write about our patients, it's about how we talk about them to colleagues, how we present them on rounds, etc. So, it's not included here because we oftentimes don't write this, but we do describe a lot of our very sick patients as disasters. And if your family member overheard you calling their patient a disaster, think about how that would affect them. Oftentimes on rounds, you'll find me correcting, residents or interns or students who are saying the patient is refusing or is being aggressive and, X, Y, or Z. And we talk about, taking a step back and trying to explore that a little bit more detail. One, acknowledging our frustrations that sometimes it's hard to take care of patients. But two, also trying to make sure that we don't lose empathy for our patients and then ultimately provide them worse care. So I think most of you here would probably agree that getting vital signs at 11 p.m. and 4 a.m. when you're going to be discharged is really annoying. And so, kind of putting yourself in their shoes, certainly, to be mindful of things.
Great point. Thank you. Thank you, Dr. Tsega. Dr. Wiseman, do you have anything?
No, I think that's it. Thank you so much, Dr. Tsega, for joining us. This was eye-opening as always, and I really appreciate it.
Thanks for having me, everyone.
Thanks, everybody.
Thanks for the amazing talk. Thank you. Have a great afternoon.
Thanks. Good luck down there.
Thank you.